Hi everyone, this is Dr. Prasad, a consultant emergency medicine at Yashoda Hospital, High Tech City. So today, as every week, we bring about a very interesting topic. So this week we have come with thermal injuries, which is a very important and commonest emergency that we see every day, almost in an emergency department, and we often sometimes get a minimal, small scar-like burns at home. So basically, to speak on emergency aspects of the thermal burns, so today we have a eminent speaker, Dr. Madhukiran, academic head of emergency medicine, Yashoda Hospital, Somajuguda. So over to you, Dr. Madhukiran.
Thank you, sir. Good evening, everyone. So today I'm going to discuss regarding the thermal injuries as well as the environmental injuries. So first, in thermal injuries, the first thing is we have to stop the burning process. So we have to extinguish the fire and we have to remove people from the heat source causing flame or scalds. For adherent material like tar, ensure that burns have been cooled down to touch. Decontamination from chemical agent exposure is early priority with care to protect first responders from the contamination. So it's like more of the scene safety and as well as the patient safety. We have to remove the patient out of the danger zone. So brush and dry any chemical powder from the wound and irrigate with copious warm irrigation. Use a decontamination shower. Cool burn wounds with room temperature running water for 20 minutes. And care must be taken to avoid hypothermia, especially in the larger burns. And important thing is do not use ice. Once the burning process has stopped, quickly cover the patient with warm, clean, dry linens to prevent the hypothermia. And after that, after stopping the burning process, after doing the initial steps, and we'll go with our primary survey. Primary survey starting with the airway. So in airway, early evaluation is important to determine the need for the endotracheal intubation. So a history of exposure to smoke or chemical vapors in an enclosed space should increase the concern for the airway injury. So mainly in inhalational injury, uh, there is early airway compromise. We have to plan for the early endotracheal intubation because if once airway edema develops, we can't intubate the patient. It is very difficult to intubate the patient. So the factors that affects the upper respiratory tract airway obstruction are large bun size and deeper burns to head and face and burns inside the mouth. So patient presented with the signs of respiratory distress should be intubated. And another thing is whenever there is a uh, uh, burn in the closed environment, we have to suspect the CO poisoning. For that reason, we have to send carboxyhemoglobin levels. So a level greater than 10% often indicates significant exposure. So children with burn injuries are at a higher risk for airway obstruction than adults due to their smaller airways. So circumferential burns to neck and chest may also compress the airway and gas exchange. So clinical manifestations of subglottic inhalational injury must be subtle and progressively appear within 12 to 24 hours. So when in doubt, examine the patient oropharynx for signs of inflammation, mucosal injury, soot in the pharynx and edema. If you find any of these findings, then you have to plan for the intubation. So situations that should prompt for immediate intubation. So signs of airway obstruction, number one, like hoarseness, stridor, axillary respiratory muscle use, and sternal retractions. If you are seeing any of these signs, you have to plan for the intubation. Next, signs of the respiratory compromise. That is like inability to clear secretions, respiratory fatigue, poor oxygenation or ventilation. And next is the decreased level of consciousness where patient airway reflexes are impaired. And very large body surface area flame burns, typically greater than 40 to 50% burns. And next indication is the extensive and deep facial burns and burns inside the mouth. If you see any of these indications, and you have to plan for the endotracheal intubation. Next, it is important to place an appropriately sized endotracheal tube for age and sex. And important thing is first intubation attempt should be definitive one and performed by the most experienced clinician available. So whoever is the senior in the year, they have to do the first attempt because whenever you attempt, the airway edema will be increased. Then next, it is very difficult for the next person to place the tube. So placing a tube that is too small will make ventilation, clearing of secretions, and bronchoscopy difficult or impossible. So better to choose at least a tube of size 7 mm of interior diameter. Okay. And next, after airway, then breathing. Breathing, you will check for the saturation and you will check for the respiratory rate and you will auscultate the lungs for any wheeze. Okay. After that, you have to get one chest X-ray and ABG. So usually these values deteriorate over time. So in case if initial X-ray and ABG are normal, doesn't mean that we can exclude the inhalational injury. So it may develop in 12 to 24 hours. So continuous monitoring is required. So smoke inhalation can cause airway compromise either from chemical or particulate injury and is treated with a supportive care. Hypoxia may be related to the inhalational injury, inadequate ventilation due to circumferential burns, or thoracic trauma. So administer 100% O2 to burn patients during the primary survey. So always assume carbon monoxide exposure in patients who are burned in enclosed areas. The diagnosis of CO poisoning is made from the history of exposure and direct measurement of carboxyhemoglobin. So patient with carboxyhemoglobin levels less than 20% may not have the symptoms. So effects of the carbon monoxide levels are headache and nausea if it is 20 to 30%, and confusion if it is 30 to 40%, coma if it is 40 to 60%, and if it is greater than 60%, then death will happen. So in main thing in breathing is assess for uh, in airway we have assessed for the signs of respiratory airway compromise, and if there is any signs we have intubated. In breathing we have to assess the breathing. So if there are circumferential burns which are compromising the breathing, you have to go for the espirotomy as early as possible. Next, elimination half-life of CO is approximately 4 hours when the patient is on room air. So, but it can be reduced to 40 to 50 minutes by breathing on 100% oxygen. So, standard pulse oximetry is showing 98 to 100% oxygen, and ABG and co-oximetry we have to do. And we have to suspect cyanide poisoning along in case if combustion is possible with burns occurring from the combined spaces. So signs of cyanide toxicity are persistent with hypotension and profound metabolic acidosis that are unexplained by other causes. So in pre-hospital and emergency department setting, the candidates for preventive treatment of cyanide toxicity have following combination. Number 1, CPR in the field. Number 2, loss of consciousness. Number 3, GCS less than 10. And number 4, lactates 10 and carboxyhemoglobin greater than 10. So if you're suspecting, if you're facing any of these things, you have to suspect the cyanide poisoning, and antidote is hydroxycobalamin, 5 grams IV, first dose, and if there is symptoms persist, you have to go for second dose of 5 grams IV, maximum of 10 grams you can give. Next, circulation. So in burns, mainly there is a progressive fluid loss. So progressive burn resuscitation should be initiated immediately for patients with large burn injuries. If peripheral IV insertion is not rapidly successful, consider intraosseous access to start the resuscitation. So isotonic fluid should be administered in the pre-hospital setting and continued in the primary survey. So as per the age, we can start 125 ml per hour for age less than 5 years and 250 ml per hour for 6 to 12 years and 500 ml per hour for age 13 years or old. This is for the pre-hospital settings. So before shifting the patient to the ER and from the in the ambulance, you have to start at this rate. Okay. Delay only promotes burn shock. So on the other hand, bolus fluid is discouraged unless patient is hypotensive or other signs of severe hypovolemia, as it provides thought spacing rather than simply increasing the intravascular volume. So peripheral pulses should be evaluated in all extremities during the primary survey. In circulation, as you know, mainly we have to check the pulse rate, blood pressure. So tachycardia will be there because of patient is anxious and patient is in pain. And shock we have to see mainly. If there is no shock, only consider the maintenance fluid. If there is a shock, then only consider the boluses. Next, disability. Disability, we will assess the pupils, GCS and GRBS. Okay. So mental state change can aid in early diagnosis of hypoxia or shock. So burn patient can develop altered status maybe because of hypoxemia or because of the hypotension. So we have already identified these things in the breathing and circulation, and we have to continue further. In case if GCS is very low, so patient may not able to uh, protect the airway. So we have to intubate the patient. We have to consider intubation in case if patient GCS is less than 8 and if patient did not intubate in the airway. Next, exposure. So hypothermia is a life-threatening finding in the primary examination. So a limb-threatening cold injury should be rapidly assessed. Next, secondary survey. In secondary survey, history is very important. So we'll start with the ample history. And for patients with burns, attention should be paid to the mechanism of burns, duration of the contact, circumstances of the burn, and time of the injury. So patients can sustain associated injuries while attempting to escape a fire, and explosion can result in the fractures and internal injuries. So be aware that some burn injuries may be intentional. So individuals may attempt suicide through self-immolation, and both children and vulnerable adults may experience abuse. So match the patient history to the burn pattern, and if the account of injury is suspicious, consider the possibility of an intentional injury. Next, so body surface area and depth assessment. So we have to apply the rule of 9. So rule of 9 is a practical guide to determine the extent of burn using calculations based on area of partial and full thickness burns. So this is the thing, just go through the image. So based on that, we have to calculate the percentage of burns. In case if you are not sure regarding the percentage of burn, so you can use the palm area of the patient. So it will palm area of the patient will be contribute to the 1% of the burns. So if burns are patchy, you can use that method. So tips to prevent over or underestimating the size. So do not include superficial burns in size estimation. That is calls. And use the rule of 9, recognizing that children have proportionately larger heads than adults. For irregular or oddly sized burns, use the patient palm and fingers to approximate 1% body surface area. For larger burn surface, it may be easier to count the unburned areas and subtract that from 100. So remember to log roll the patient to assess the posterior side burns. Next, types of burns. Superficial or first degree burns. Example, some burns. Characteristics are erythema, pain, and do not blister. These are not life-threatening, no significant inflammatory response. Resuscitation is not included, and it is not included in the total body surface area calculation. Okay. So next is the partial thickness or second degree burns. So characteristically, it's a superficial partial thickness or deep partial thickness. Superficial partial thickness burns are moist, painful, and homogeneously pink, and they blanch to the touch and may have intact blisters. And deep partial thickness burns are drier, less painful, red or mottled in appearance, and do not blanch to touch. And next is the full thickness burns are third degree burns. So these usually appear leathery. The skin may appear deep red, brown, or waxy, while white. The surface is generally dry and does not blanch and is painless to touch or pinprick. So this is how you have to classify the burns. So go through the image once. So here you can see epidermis, dermis, subcutaneous tissue, and muscle. In first degree burns, only epidermis is involved. In partial sheet thickness, second degree burns, so you can see epidermis and dermis got involved. In full thickness burns, epidermis, dermis, and subcutaneous tissue, and sometimes it will extend to muscles and bone also. So calculate the adjusted fluid rate. So adjusted fluid should be administered as warm isotonic crystallite, preferably ringer lactate. So previously we used to follow the Parkland formula, but with the Parkland formula, there is a possibility we can infuse the fluids. I mean, we will overhydrate the patient. So which will result in the tissue edema and like limb edema and third space loss of the fluid. So better thing is to follow the modified Brooks formula. So these are the modified Brooks formula where we are adjusting the fluids as per the patient requirement. So here fluid should be adjusted on an hourly basis to maintain a goal of urine output of 30 to 15 ml per hour in adults. So for pediatric patients, the goal is 1 ml per kg per hour. So based on the urine output, we'll change the flow. So first we'll calculate the initial flow rate, and after that we will reduce or increase the rate as per the requirement of the patient. For example, if the patient urine output is below the target rate, the hourly fluid rate for the burn resuscitation should increase by 10 to 30%. In case if patient urine output is above the goal, the hourly rate should be reduced by 10 to 13%. So in this way, we can tailor the fluid management to the patient. So if you see for thermal or chemical burns for adults and children greater than 13 years old, it is 2 ml per into kg into total body surface area by 16. Then you will get the per hour ml per hour adjusted hourly fluid rate. And urine output goal is 0.5 ml per kg per hour or 30 to 50 ml per hour. For children below 13 years, we'll multiply with 3. And for infants and children less than 30 kg, we'll multiply with the 3. But here the thing is, for infants and young children less than 30 kgs, they have less glycogen stores and they are more, and their metabolism is very high. So they are more prone to hypoglycemia. For that reason, along with the lactated ringer, we are adding D5 so that here dextrose, we are adding dextrose to prevent hypoglycemia, not to treat the burns. So lactated ringer, as usual, we will calculate. And next, electrical injury for all age groups. For all age groups, we'll multiply with the 4. 4 into lactated ringer into kg into percentage by 16. But here the urine output goal is 1 to 1.5 ml per kg per hour until urine is clear of the pigment. So children less than 13 years old require D5 at maintenance rate. Okay. So only thing for infants and young children is, as they have low glycogen stores, we have to add dextrose to the linger lactate. So here one example of adjusted calculated fluid calculation. So a 100 kg man with 80% total body surface area of burns has an estimated need for 2 into 80 into 100, that is 16,000 ml in 24 hours of crystallite fluid. The total volume estimate should be divided by 16 to obtain the adjusted fluid rate. So though he should have received 500 ml per hour in the pre-hospital phase, the fluid rate should be increased to 1000 ml per hour during the secondary survey. In subsequent hours, the fluid rate should be decreased as based on the urine output response. So traditional formula have caused some clinicians to adhere too rigidly to administering the first half of the total fluid in first 8 hours and second half in the following 16 hours. Once consequence of fluid resuscitation is the development of edema, which takes to develop it. In anticipation of this, the longer IV catheter should be used if possible, and endotracheal tube should be checked frequently to ensure no change in the position. The key principle is that fluid resuscitation must be adjusted based on the patient's response. The calculations do not prescribe the fluid rate for hours subsequent to the initial assessment. The clinician should base the reduction in IV fluid rate on urine output and titrate to a lower rate if urine output is adequate. So hope everyone understood why we are using this adjusted fluid rate. So during first 24 to 48 hours of burns resuscitation, fluid bolus should be generally avoided unless patient is hypotensive. Hypertension indicates the patient is in shock and the resuscitation is inadequate. In such a case, a bolus is appropriate and hourly fluid rate should be increased. Low urine output by itself is best treated with gradual titration of the fluid rate. Very small children, this thing we already discussed. Very small children should receive RL containing the 5% dextrose at maintenance in addition to the burns resuscitation volume. So next, peripheral circulation in circumferential extremity burns. To maintain peripheral circulation in the patient with circumferential extremity burns, the clinician should remove all jewelry or constricting clothing material and elevate the limb and frequently assess the neurovascular status of the affected limb. So compartment syndrome results from pressure inside an inelastic body surface increasing to the point that interfere with the perfusion to the structures within the space. For that reason, we have to remove all the tight constriction rings. In buns, this condition results from the combination of decreased skin elasticity in deep buns and increased edema in the soft tissues. So compartment syndrome, when to suspect the compartment syndrome. So when if pain greater than the expected and out of permission to the stimulus or injury. Number 2, pain on passive stretch of the affected muscle. Number 3, tense swelling of the affected compartment. Next, paresthesias or altered sensations distal to the affected compartment and loss of pulsation. So in compartment syndrome, loss of pulsations is a late finding. If you are seeing so don't expect that you have to wait for the loss of pulsations. So first 4 things you have to assess, and if there is anything, uh, compartment syndrome is there, and plan for the extraotomy as early as possible. So compartment syndrome may also occur with circumferential chest or abdominal burns and be diagnosed by increased peak inspiratory and abdominal pressure movements. So chest and abdominal hysterectomy is performed along the anterior axillary lines with a cross incision at the junction of the thorax and abdomen, usually relieve the problem. For patient with high voltage electrical injury, compartment syndrome may develop in the muscle fascia compartment. In such muscle compartment fasciotomy is required. So pain and anxiety management. In severely burned patient may be restless and anxious from the hypoxemia, hypovolemia rather than the pain. So consequently, manage hypoxemia and inadequate fluid resuscitation first. So opioid analgesia and sedation should be administered in small repeated doses, preferably IV. So remember, anxiety can contribute to the patient pain experience. Simply covering the wound will decrease the pain. So wound care recommendations. So use plastic wrap or non-adherent dressing for transfer. Rationale is dry dressings adhere to small shallow burns. So use small repeated IV opioid doses for analgesia. Rationale is it provides more immediate pain control that can be titrated to response. Next, prevent superficial wounds from drying. Drying can increase the pain. So frequently reassess dressing for tightness and constriction. So patient can develop deep tissue injury from constrictive dressing and ties, especially as edema develops. For that reason, you have to remove constrictive rings and other jewelry and clothing early. Be alert for deep circumferential burns. Remember that edema takes time to develop, and monitor pulses, elevate the affected extremities in these cases. So recognize that the burned skin with a scar cannot stretch, and patient with a deep tissue injury from constricting burn scar and deep circumferential burns may require sclerotomy. So chemical burns. So chemical burns can occur from the exposure to the acids, alkali and petroleum products. So chemical burns are influenced by the duration of the contact, concentration of the chemical and the amount of the agent. Once the amount of duration can be modified by the clinician, and rapid removal of the chemical is essential. If the dry powder is present on the skin, brush it away before irritating the water. Otherwise, immediately flush away the chemical with large amount of warm water for at least 20 to 30 minutes using a shower hose. Alkali burns requires even longer irrigation. Check the affected skin pH with pH paper to determine the effectiveness of the irrigation. Neutralizing agent offer no advantage over the water lavage. So because reaction with the neutralizing agents can produce heat and can cause further tissue damage. So for eye irrigation, a small caliber cannula can be fixed the palpable surface. In the event of the hydrofluoric acid burns, topical calcium should be applied. Once initial decontamination has been started, clinician should then investigate more thoroughly the type of exposure. Next, electrical injury. So electrical injury classified into two types, high voltage and low voltage. High voltage means greater than or equal to 1000 volts. Low voltage is less than that. So differential heat generation between the superficial and deep tissues allows relatively normal overlying skin to coexist with the deep muscle necrosis. So because of that, the skin surface might be normal, but there is every possibility there can be the underlying muscle necrosis. So severe electrical injuries usually result in acute contracture of the affected extremity. So a clenched hand with a small electrical contact wound should alert the clinician that a deep soft tissue injury is likely and fasciectomy is necessary. So all patients should undergo ECG as an adjunct to the physical treatment because we can see the any ECG changes. ECG for hyperkalemic changes. Patient with no loss of consciousness, a minimal wound burden, a normal ECG may be safely discharged after low voltage injury. And prolonged monitoring is required for the patients with severe burn, loss of consciousness, or exposure to high voltage or cardiac arrhythmias or abnormalities on initial ECG. Any patient with electrical injury who develops signs of acute kidney injury or failure should have a 12-lead ECG and continuous monitoring. Electrical injuries often associated with falls and frequently occurs at work. So you have to evaluate for the other injuries also. So patient with high voltage injury should be assessed for the mechanical trauma, including spinal column and spinal cord injuries. So clinicians should also remember that with electrical burns, muscle injury can occur with few outward signs of injury. So serially assess the patient for compartment syndrome and recognizing that electrical burns may initiate the fasciectomy. So another thing, rhabdomyolysis from the electricity traveling through the muscles results in myoglobin results, which results to the acute kidney injury or renal failure. If the patient urine is dark, assume the hemochromogens are in the urine, then test for myoglobin to confirm if possible. So resuscitation to the electrical injury should start based on the following calculation. You should calculate 4 into kg into 4 ml into kg into total body surface area as visible surface injury, often grossly underestimate the content of the deeper injuries. As in thermal trauma, the value should be divided by 16 to obtain the hourly fluid rate for secondary survey. If red pigmented urine is present, the urine output goals are 100 ml per hour in adults and 2 ml per kg per hour in children. And once the urine is clear of red pigmentation, fluids can be titrated down to standard urine output targets. So burn platens in vulnerable individuals. In vulnerable individuals like elderly and children, so we have to suspect. So when to suspect intentional burns. So first thing is contact pattern with the clear edges should arouse suspicion as they may reflect hot objects held being against the patient. Next, scald burns on the soles of a child's feet may suggest that the child was placed into hot water versus hot water fall on them. And sparing the buttocks is another classical sign as contact with a bathtub or basin surface can protect these areas during the forced immersion. Bathing burns in older or dependent adults are also concern for abuse or neglect. Old burn injuries in the settings of a new traumatic injury such as fracture or a burn wounds of different age should also raise the suspicion for the abuse. Above all, mechanisms and pattern of injury should match the history of the injury. And guidelines for consultation and transfer we should take into the consideration of the local burn preparedness and existing regional capabilities. So in thermal burns, so immediate consultation with consideration for transfer is required for full thickness burns, partial thickness burns greater than 10% of the total body surface area, any deep partial or full thickness burns involving the face, hand and genitalia, feet, perineum or over any joints, patient with comorbids, patient with concomitant traumatic injuries and poorly controlled pain. So all these patients we have to consider the immediate consultation and consideration for the transfer. And consultation recommendations in thermal burns. So partial thickness burns less than 10% and all potentially deep burns of any size. Next, for inhalational injuries, all patients with suspected inhalational injury, we have to consider the transfer. And patient with signs of potential inhalation such as facial, flash burns, singed facial hair or smoke exposure, we have to do the consultation. Next, pediatrics less than 14 years or less than 30 kgs. So all pediatric burns may benefit from burn center referral due to pain, dressing change needs, rehabilitation, patient or caregiver needs, or non-accidental trauma. For all these things, we have to consider transferring to the burn center. Next, chemical injuries. All chemical injuries, we have to consider the transfer. Electrical injuries. All electrical injuries, high voltage greater than 1000 volts, and lightning injuries, we have to consider to transfer to the higher center. So next, cold injury. So cold injury, frostbite and non-freezing injury. Frostbite, so increases the severity of the factors that increase the severity of the cold injury are temperature, duration of the exposure, environmental conditions, amount of preventing clothing, and patient's general state of the health. So the factors which increase the severity of the cold are the lower temperatures, immobilization, prolonged exposure, and presence of the peripheral vascular disease and open wounds. So if any of these factors are there, there is a high risk of, there is high risk of the more severe cold injuries. So frostbite. So frostbite can occur when tissue freeze, ice crystal formation causes cell membrane injury, microvascular occlusion, and subsequent tissue anaxia. So tissue damage can also result from the reperfusion injury after rewarming. So careful rewarming is necessary. So classification of the frostbite. First is the first degree frostbite. We can see the hyperemia and edema present without skin necrosis. Second degree frostbite. Large, clear vesicle formation accompanies the hyperemia and edema with partial thickness skin necrosis. Third degree frostbite. Full thickness and subcutaneous tissue necrosis occurs commonly with the hemorrhagic vesicle formation. Fourth degree frostbite. Full thickness skin necrosis occurs including muscle and bone processing to the necrosis. So points to remember in the frostbite. So typically the affected part is initially cold, hard, white and numb. Initial treatment often applies to all degrees of frostbite and the classification is often not prognostically accurate. Patient with a third degree frostbite can develop severe swelling of the extremity with rewarming. So clinician should anticipate the potential for reperfusion injury. And prevention of further tissue injury can be aided by the elevation of the extremity, keeping the affected area free of the constricting webs. So muscle compartments must be frequently monitored. So clinician should also remember that demarcation between the live and dead tissue may take days to week to develop, and monitoring the site for infection is also critical. So non-freezing injuries. Non-freezing injuries is due to microvascular endothelial damage, stasis and vascular occlusion. So trench foot or cold immersion hand describes a non-freezing injury of the hand or feet, typically seen in soldiers, sailors, fishermen, those who are unhoused. The skin injury results from repeated and prolonged exposure to wet conditions and temperatures just above the freezing. That is 1.6 degrees to 10 degrees Celsius or 35 to 50 degrees Fahrenheit. Although the entire foot can appear black, deep tissue destruction may not be present. Alternating arterial vasospasm and vasodilation occurs with affected tissue first cold and numb, the progressing to the hyperemia in 24 to 48 hours. With hyperemia comes intense painful burning and dysarthrias as well as dysesthesia as well as edema, blisters, redness, ecchymosis and ulcerations. So management of frostbite and non-freezing cold injuries. So should begin immediately to decrease the duration of the tissue freezing. Do not attempt to rewarm if there is a risk of refreezing. So replace constricting or damp clothing with warm blankets. Immerse the injured part in recirculating water at constant 40 degrees until pink color and perfusion returns. Usually it will take 20 to 30 minutes. So this treatment is best accomplished in an inpatient in a large tank such as whirlpool tank or by placing the injured limb into a bucket with warm running water. So excessive dry heat can cause a burn injury as the limb usually insensate. So do not rub or massage the area. Rewarming can be extremely painful and adequate analgesia is required. So consider good analgesia while you are doing the rewarming. So reperfusion of the large areas can result in the reperfusion injury that can be identified with acidosis, hyperkalemia and local swelling. Therefore, it is important to monitor the cardiac status and peripheral perfusion during the rewarming. So, thrombolytic therapy. So, referring hospitals and clinicians should discuss with the regional referral unit for the use of the thrombolytic therapy in acute frost injury. So, thrombolytics can be considered in patients presenting within 24 hours of injury. So, thrombolytic therapy is most effective when developed as a part of protocol of care than as a ad hoc strategy. For example, for patient with tissue cyanosis, CT angiography can be used to assess distal perfusion. So in case if CT angiography is suspecting there is a occlusion of the peripheral arteries, you can go with the thrombolytic therapy. The dose is 0.15 mg per kg over 15 minutes, followed by 0.15 mg per kg per hour for next 6 hours. So this is the dose. The maximum dose should not exceed the 100 mg. Antibiotics. So systemic and empirical antibiotics are not indicated and reserved for the only infections. So keep the wound clean and leave uninfected blebs intact for up to 7 to 10 days to provide a sterile biological resin that protects underlying epithelium. So tobacco, nicotine and other vasoconstrictive agents should be withheld. With all cold injuries, physical estimation of injury, depth and tissue damage is usually accurate until the demarcation between the live and dead tissue is evident. This often requires several weeks or months of observation. So dust the wound with a local antiseptic to help prevent the bacterial colonization and debride them once the demarcation has been developed. Next is the hypothermia. So hypothermia is defined as a core temperature below 35 degrees centigrade and severe hypothermia as any core temperature below 32 degrees centigrade. So all injured patients susceptible to hypothermia and any degree of hypothermia is detrimental. Accidental hypothermia is determined by esophageal, bladder or rectal temperatures. So staging and management of hypothermia. Stage 1. So symptoms are patient should be conscious and shivering will be there. So core temperature will be around 32 to 35 degrees centigrade. Treatment is warm environment, warm clothing, active movement, warm oral fluids. So our traditional warming techniques we can use. Next, stage 2, impaired consciousness and no shivering. So core temperatures might be 28 to 32 degrees centigrade. So requires cardiac monitoring, you have cautious movements to avoid arrhythmias, full body insulation, active external and minimally invasive rewarming techniques, chemical, electrical or forced air heat packs or blankets, warm IV fluids we can use. Next, stage 3. Unconscious vital signs are present. So temperature might be 24 to 28 degrees centigrade. All the above plus, we have to intubate the patient as patient is unconscious, rewarming with the extracorporeal support if available. So stage 4, no vital signs and core temperature should be less than 24 degrees. So all of the above with CPR and up to 3 doses of adrenaline and defibrillation and continue if patient responds. In hypothermia, there is high possibilities patient can become, we can get the ROSC with a minimal neurological damage. So prolonged CPR is required in these patients. So next is the heat stroke hyperthermic injury. So it can be exertional heat stroke or classic heat stroke. Exertional heat stroke typically occurs in young individuals performing vigorous exercises in a hot environment. So the heat generated from the intense musculoskeletal activity cannot dissipate well and leads to rise in the body temperature. So classical heat stroke. So typically results from prolonged passive exposure to heat such as during heat waves, common in older adults and pre-existing comorbidities. So typical triad of hyperthermia is altered sensorium and exposure to extreme heat or exertion and temperatures between 40 to 43.6 degrees Celsius core body temperature. So CNS system alteration is seen in heat stroke, often presents rapidly and is non-focal and may contain lethargy or delirium. Cooling should be we have to begin immediately in the pre-hospital setting and should continue throughout the transport and into the hospital setting. Cold water immersion is the first line intervention and cooling the patient should proceed to 38.9 degrees Celsius. And care for organ dysfunction is supportive. So suspected heat stroke, measure core temperature if greater than 40 degrees, heat stroke is likely. immediate cooling, move patient to the cooler environment, begin external cooling, immerse in ice water, place ice packs, and spray skin with water and continuously fan. Next, hospital cooling, external cooling, and intravascular cooling cannulas. Thank you. Any questions?
Yeah. Thank you, Dr. Madhukiran. I think it cannot be more simpler than that. And if you have any questions, we'll take.
Yeah, okay.
So it looks like the chat box it is empty. And thank you so much for your valuable time. And indeed, it was definitely more helpful to practice after your session.
Thank you.
Thank you.